This one is going to be about the on-call issues. All right, so let me ask, first of all, how many people in your emergency department have significant on-call specialty issues? Okay, good, because otherwise I was just going to move on to the next lecture. All right, well, amongst other things that I've done throughout my career, and I'll show you all this in just a second, I've been involved in a lot of advocacy policy and a few other things. So what I'm going to talk about first, and I've also been involved with EMTALA and been an EMTALA compliance consultant. And I used to talk a lot about ED crowding. And we still have issues with ED crowding, but I believe that the on-call issues are now beginning to actually move ahead of the crowding issues. So who am I? Sherry already did a pretty good introduction. I've done a lot of things throughout my career and then moved on to Microsoft a few years ago, and we'll talk a bit more about that. But the most important thing here is that for about 8 years I was the EMTALA compliant consultant for the Arizona QIO, Quality Information Organization, which meant I was the one reviewing EMTALA cases for Arizona for CMS. I was sort of on the prosecutor's side. So I got to see both sides of that. So I have a lot of experience with that. But if you say that, I'm not a lawyer, I'm not a hospital administrator, I'm not a government official, I'm not here to tell you how to practice medicine or anything. I'm just trying to help you manage through this on-call issues. Now, this is me on the front of the USA Today. And what you can't see here is right down here. And when I called my brother up and I said, hey, I'm on the front of USA Today today, he sent his secretary out to go get a copy of it. She comes back, she's all diaphoretic and sweating and everything. And she says, I didn't know your brother was the Unabomber. All right, because that's what was right down here. And so that was 1996. 13 years ago, and that was at the height. So this problem has been going on for a long time and continues to get worse, and we'll see what happens with the new plan. So I do have to do a disclaimer here. So like most of you, I'm an emergency physician by federal law. You know, my services are free, and you know, you get what you pay for, of course. And you know, nothing I should say should be construed as personal, whatever. You know, you can read the rest of that for yourself. So if you want anything about this, I do not release the slides. The reason is because then I go to meetings, I start seeing my slides. And but I do have a document which you should have printed out, or if you want more information, be specific, I'd be happy to help you through that. So my email address is very easy. It's ttaylor@acep.org, and so I get 1,000 emails a day. One more is not going to kill me. Rick Blum, good friend of mine, past president of ACEP, said this: for millions of Americans, emergency medicine and emergency physicians are the only thing between health and no health care at all. All right, how many people believe that? Yeah, absolutely. And unfortunately, if Obama gets his way, and actually I voted for Obama. I'll talk about those reasons later. But if he gets his way, is this problem going to get worse or better? Anybody know? We already know this answer, by the way. We know because of the experience in Massachusetts. All right? Because ED crowding got worse once everybody got insurance. Because they removed the final and ultimate barrier to access for health care, and that was funding. And so all of a sudden people didn't have primary care physicians, but they did have insurance. So ACEP has been very involved with all these activities. They have policies about that. If you're having significant on-call issues, you should make yourself familiar with those. And again, I'd be happy to provide those, or it's already in your handout. They've done a lot of things, including having this rally at the Capitol with about 5,000 people all in white coats sitting there. And you know, I like this shot because this is John Rupke, who was the second speaker of the ACEP Council, and then the new guys. All right, so there's kind of that juxtaposition between old and new, and they're still fighting the fight. All right, so this is a little study that was done. Predictors of on-call specialty response. 1 in 10 didn't even call back. Hospitals in poor neighborhoods had more difficulty, big surprise, and increased funding was the conclusion with a solution. What I'm here to tell you is that funding alone is not going to fix this. So if you thought you could spend your way out of this, you really can't. And part of that is because doctors' morale is really hurting. All right, you know, 60% are considering leaving practice. 70% knew a doctor who stopped practicing. I'm one of them. Why? Low reimbursement, loss of autonomy, bureaucratic red tape, all those things that you know. The point of this is, if you really want to solve the on-call specialty issues at your facility, you have to know what the problems are, what the issues are with those physicians, which means you actually have to talk to them. You would be amazed at the number of hospital administrators that think they can go to a meeting like this of their peers, listen to a lecture, and then go back and implement that, and they never talk to the physicians. They don't talk to the emergency physicians. They don't talk to the on-call physicians. They just assume that they know what the problem is. I spent years talking with people, and what I found out is it's not all about money. It's really a lot about this loss of autonomy and this sense of fairness. So if you don't solve the right problem, you will not get the right result. All right? So anybody know how much you have to pay a bomb technician to defuse a bomb without protection? Now, knowing that the only difference is an open and closed casket. All right? But nobody's crazy enough to go defuse a bomb without protection. Yet we ask physicians, particularly emergency physicians, to do that every day. To put your personal wealth, your career, your kids' college education on the line to stay up all night and help people. Okay? So I'm an example of that. In 2006, the governor vetoed the liability bill that I had worked on, and I left. I quit emergency medicine. I left the state of Arizona. All right? 4 years later, Obama appoints her as the Department of Homeland Security. She leaves. The Secretary of State, a Republican in healthcare, becomes governor. And the bill passes without fanfare. All right? That's politics. But this is a huge issue, and it's a huge issue for your on-call. So, you know, what do people think about defensive medicine? Well, you know, about 10% don't think it's, you know, it's just inevitable, so I don't really practice defensive medicine. But a huge portion of people, you know, practice. How many people in here practice defensive medicine? Okay? So the rest of you have been sued. All right. You know, I agree. I think there are issues around that, but you can believe that your on-call colleagues don't want to take emergency call because the liability is high and the reimbursement is low. And so these are some of the reasons that have been identified as why you will have on-call issues. Again, if you don't address each of these, you will not be successful. Unlike what Sherry said, you really can't go to a place and say, here's a place that really solved the on-call issues, I'm going to do what they did. Because even if they've done that, it probably won't work where you're at. So this has to be very individualized, it has to be very local, and you have to make some really hard choices. And I'm going to talk a little bit about that. All right? So this is a study that was published in JAMA that showed that basically they had like 3 scenarios. I was in the emergency department. It started with that, and then it was, you know, I have a runny nose. I have something like, you know, sutures that need to be removed, and I have meningitis. All right, now they didn't say that. They just gave symptoms consistent with that. And about 80% of the people who didn't have insurance could not get an appointment or got an appointment 10 days later. All right? Big, big issue. Even people with insurance had a difficult time. I just recently tried to do my sort of annual stuff, get an appointment with a primary care, you know, get that colonoscopy I look forward to every year, and that kind of stuff. And they're booking in February, and I called this week. Okay, so it's issues. This is another thing that was published in JAMA that I like to talk about. So this patient was seen in the emergency department after having a bar fight, sent to the clinic, shows up in the clinic, and the chief complaint in the clinic was nose injury. So the doc goes in, you know, he thinks, well, the guy probably got in a fight, got a broken nose, something like that, just, you know, get him fixed up here. And he goes in, this guy's got a, you know, dressing on his nose, and he takes the dressing off. And he didn't have a nose injury, he didn't have a nose. His nose had been completely bitten off, all right? And they could not find anybody to do anything in the emergency department. Now, how many people have had that similar experience, right? Okay, so you guys need to work where I work, because one of the last patients I saw was just like this. Lady who had fallen down had good insurance. She had a wedge injury, just a big piece of her lip missing. And it's, you know, holiday weekend, and I called 12 plastic surgeons. Now, I'm at a level 1 trauma center, 800 beds in Phoenix, Arizona. This is not a small place. We did not have plastics on call for the last 3 years I practiced there. I called 12 plastic surgeons, not one of them would see her. Not just in the ER, at all. And all I did was, at the end of the day, put a dressing on it, said, go see your doctor, and maybe he can find you a plastic surgeon to fix your lip, because it wasn't an emergency. These are real issues, all right? So increasingly, the doctor's just gone. All right, so this is the challenge that you will have. Hopefully this video will play.
This man right here is my great-grandfather. He's the first cat herder in our family.
Herding cats. Don't let anybody tell you it's easy.
Anybody can herd cattle. Holding together 10,000 half-wild short hairs, well, that's another thing altogether.
Being a cat herder is probably about the toughest thing I think I've ever done.
I got this one this morning, right here, and if you look at his face, it's just ripped to shreds, you know.
You see the movies, you hear the stories, I'm living a dream. Not everyone can do what we do.
I wouldn't do nothing else.
It ain't an easy job, but when you bring a herd into town and you ain't lost a one of them, ain't a feeling like it.
All right, so you don't think that's a problem? All right, this is what I like to call stupid doctor tricks. All right, so patient is admitted with a chicken bone in the airway. All right, patient is taken to the operating room to remove said bone. All right, you have an anesthesiologist, you have an ENT surgeon. All right, they get into an argument about how the patient is going to be managed in the airway. They begin to fight, not argue, fight, physically fight, while the patient had been sedated and dies. Real case in Arizona, all right? This is the kind of issues that we're having to deal with, all right? So I think the first thing to do is to understand what the gravity of this is, and Ben Van Landingham, he again was from Arizona, from U of A, and went on to Hopkins and did this survey a few years ago. Okay, see the Mac is playing tricks on me here. So suffice it to say that 63% found that ED coverage was an issue. I know I worked for Microsoft, didn't know that. Do you have adequate, have problems with adequate coverage? No. So anyway, we all know it's a problem, all right? Again, more Mac tricks here. So this is state by state, and you see Arizona was number one. You can pick your state, but all of them, are above about 50%. So it is a global issue within the U.S. 41% of community hospitals have lost specialty coverage, and again, that continues. And when we say community hospitals, we mean other than academic medical centers, even though sort of rural, urban places are having issues with that. In fact, there's all kinds of issues. Like this, I love this one, the percentage of administrators who wouldn't even go to their own ED, 15%. Right? If that's not an indictment, I know. But the percentage of hospitals in which a lack of special physician coverage caused them to divert patients to other facilities, 76%. Huge. All right? So let's take the survey. How many people believe the on-call issues are because of managed care? Feel free to raise your hand. All right, so I'm in Arizona. I get a little bit better response there. How about lack of reimbursement? Yeah, okay. How about regulatory requirements? Okay. How about inconvenience, disruptive, just don't like it? Yeah, there you go. Liability. Sure. And EMTALA. So EMTALA, our friend, has actually become an enemy. Because an on-call physician, as long as he doesn't voluntarily accept call, has no obligation to take call or EMTALA, even if he's on staff at the hospital. EMTALA is completely a hospital requirement, and hospitals are required to compel their medical staff to provide this coverage. Huge, huge issue. All right, and then there's other things as well. Again, you have to understand what the issues are if you want to solve them. All right, so how many people believe that the Obama plan is going to make the on-call issues better? Nobody? Really? Yeah, probably not. And people think that if you insure a lot of people, that that's going to be better. Well, the fact is, it's not money. And the amount of increased reimbursement that even emergency physicians will get will be grossly offset by the increased taxes that you'll pay to do that. All right, so we're all losers in this, and on-call and other physicians, primary care physicians in particular, are going to be big losers, at least if it goes the way it is. So what did we do? In Arizona, we created this group of things that we thought would solve the problem. And this is just, if you want this summary, I published it back in 2002. I've updated it a few times, sort of an Arizona case study of all the stuff that we did to solve ED crowding, on-call, and everything else, all right? So one thing we did, we sort of had the kitchen sink for managed care. We nailed managed care. We took away everything that they wanted to do to patients. We created the imprudent layperson standard, which said if a patient comes to the emergency department, health plans were required to pay for EMTALA-related services. Required to pay. They couldn't have a statutory denial. All right? We're the only state that has that. Proposition 204 increased the funding for Medicaid. So we went, and for my emergency department, and I'll talk about, if I have time at the end, the point of service revenue capture program, but I instituted a program where we enrolled people in Medicaid in the emergency department, and we had retroactive payment. So once they became eligible, we got retroactive payment. We went from a 34% uninsured rate to a 15% uninsured rate within about 18 months because of this, right? So we largely solved the funding issues, and the on-call issues just got worse. Right? So it really turned out not to be a money issue. We also solved the liability issue at my, we didn't solve it, but we tried to mitigate it by the hospital who was self-insured. If you were an on-call physician, you got the hospital's 10 million, a bazillion million liability coverage. You didn't have to use your own malpractice. The hospital covered you. Again, that worked for a while, but over time, it just was like no amount of money type thing. So people, in fact, this thing here is, what do you do? This is actually a reporter that hurt her leg, and she went to primary care, and then she had to go to the x-ray, and then she had to go to the orthopedics. It took her like all day. Her conclusion was this: I'm just going to go to the ER next time where I can get it all done in one place. All right, so who's crowding? It's not just the uninsured. And in fact, insured patients go to the emergency department more on a percentage basis than uninsured. All right, so we published this in about 2000, and I'm just going to kind of read this real quickly. The Arizona College of Emergency Physicians hereby goes on record stating that the emergency physician community has lost confidence in the emergency healthcare infrastructure in Arizona, and that current resources supporting emergency care are inadequate to meet the needs of all patients at all times. What that says is people are going to die. Now, we published this in 2006 in December. We had the worst ED crowding issues that Christmas to New Year's. In fact, we had NBC, ABC, and CBS in my emergency department filming this whole thing. All right? And a large part of this has gone from crowding, as I mentioned, to the issues with on-call. So how many people believe that healthcare is a fundamental right in America? Okay? All right, so all the Democrats in the room. How many people believe that it's not? And how many people just don't know? All right, so problem is that we treat this as a fundamental right, okay? Read EMTALA. We fund it as a privilege. And EMTALA is the gap that fills that in. And we do so in the free enterprise system, which creates some issues, all right? So is it a right? Well, if you're old, in jail, or in Congress, or all the above, it is right. Okay? For everybody else, it's really an option. And so, John Kitzhaber, who was the governor of Oregon, was famous for saying this. Says, if basic education is something we value, why isn't healthcare? Again, this is what's going on in the public debate right now. I'm going to talk a little bit about EMTALA, which is now more than 20 years. Hey, I got a deal for you. It's high liability, inability of patients to follow up prescribed care. This turns out to be a huge issue with on-call physicians that is not often recognized or addressed. So again, one of the last patients that I saw was a mandible fracture, been to 2 previous emergency departments, turned away, referred to ENT, plastics, everybody else. All right, he tried to follow up, didn't have insurance, and the last guy, when I called, the ENT guy that was on call for me that handles our mandible fracture, he says, look, I'll be happy to see the guy in the office. The problem is I can't get him back into a surgery center back in the hospital because he has to put down $3,000 for the hospital. Right? And I said, well, that doesn't sound right. You're doing your job, but the hospital's not following through, and the hospital has an EMTALA obligation, just like everybody else. So, being the industrious emergency physician that I am, I called up the hospital CEO the next morning after my shift, and I said, hey, look, I had this guy, and he did da-da-da. And the hospital CEO says, well, it's not an emergency. Says, now he's been to 2 of our sister hospitals. This was the 3rd, and no one will take care of him. He says, at what point does it become an emergency? And we had this little discussion back and forth. And he said, okay, fine, we'll take care of it. And plus, we had this Medicaid program that's going to be covered anyway, all right? So I thought I had the whole thing solved. So now it's Saturday morning. And, I've been working another night shift. And I get a phone call, my own home phone number, from the anesthesiologist. Says, well, it's great that you figured out how to get the hospital paid and this guy, but you didn't figure out how to get me paid. So I'm not going to do the case. I said, look, here's my Visa card number. If you don't get paid, just charge me. I'll pay for it. The guy said, well, you don't need to do that. I said, yes, I do. I do need to do that. Because I'm here seeing patients. I have no guarantee reimbursement, but apparently the rest of the community won't. Well, the guy got taken care of, got medicated, and it was all paid for. All right? So anyway, so this is a huge issue, particularly with hand surgery and some other stuff. So that was the big beef with the hand surgery. It says, look, I can put the hand back on, but if they don't get therapy, they show up in court with a hand like this, and they say it's my fault. All right? So it's inconvenient and disruptive. This turned out to be another huge, huge issue, right? So these guys, this burning of the candle at both ends just doesn't work anymore. In fact, most of the guys, at least at our place, had to schedule their office off the next day because they knew they were going to be up all night. Well, you know what? Those people that they have in their office still are going to get paid, right? They're not going to take the day off. So how do we deal and how do we address that issue? And there are some ways to do that as well. How many people believe that your emergency department is a hostile, inefficient work environment? Every hand should go up here, otherwise you wouldn't be here, right? Yeah, so, I mean, we're emergency physicians, we're adrenaline junkies. We love to go in there and we love to mix it up, We understand our system. Let me tell you, the on-call physicians at your hospitals don't understand how the emergency department works. And in fact, they are not exactly treated with open arms when they show up. And what happens? They come in, they ask a nurse, can I do something? And he says, just a minute, I'll get to you when I can. Because I'm taking care of this heart attack victim. I don't have time, That's the reaction they get. Now, who wants that? Because what do they normally do? They have a scheduled patient. They walk in. The patient's asleep. They don't even have to talk to the patient. And everybody's sitting there handing them stuff, right? It's all nice and clean. All right? That's their normal environment. All right? That's what they expect when they come to the emergency department. What do they get? I love the GI guys, right? They show up to do that, esophageal foreign body, and they got to wait for the equipment. They got to wait for the nurse. They got to wait for the tech. They got to wait for this. And then they push it through. Then they got to wait for the next thing. It takes like 3 hours to do a single, and they get paid the same amount of money that they would have gotten to do 3 an hour in the surgery center. All right? Who wants that business? All right? And then then you don't even get paid for it. Great. So you have to solve those issues as well. All right. So we talked about EMTALA. I'm going to run through this very, very quickly because I think you guys probably understand that. Again, the hospitals are required to provide the services. The on-call medical staff at your hospital or your medical staff at your hospital have no obligation under EMTALA. All right. They only get that by virtue of volunteering to be on call. It's a voluntary program. In fact, your hospital doesn't have to comply with EMTALA if they do not wish to accept Medicare and Medicaid. Okay, it is a voluntary program. That's how they get past the slavery thing, right? But it does regulate physician behavior once they are on call. All right, and it makes the physician equal or more at risk than the hospital for EMTALA sanctions. In other words, as the emergency physician, as the on-call physician, if I screw up, if I violate EMTALA, I can be fined $50,000 per incident, and I can lose my ability to bill Medicare. Same thing can happen to the hospital. The difference is it's not the hospital administrator losing his job, it's me. And there have been examples of that. All right? So it is the de facto on-call policy for every Medicare participating hospital. Okay? And if you violate, you will get cited or possibly sued in the civil courts. And it's really exacerbated the issues. And so EMTALA, our friend, has really become one of the issues. Now I'm going to skip over this because I've pretty much already talked about that. I'm going to run a little short on time. So anyway, EMTALA was brilliant public policy. It's brilliant because it allowed America to ignore the issue of the uninsured for now going on 20 or 30 years. I think it was a testament really of the resiliency of providers that they were able to withstand the largest unfunded mandate in the history of the United States. And that was EMTALA, all right? Something like, $50 or $60 billion a year on the backs of private. I think it's run its course. We can't get rid of it until we solve the problem that started it, and that was funding. and it's the cure that is now the symptom of an ill and dying healthcare system. You don't think it's an issue? Well, it wasn't an issue back in 1994, but CMS figured this out, and hospitals have quite frankly figured it out too. There was a huge upsurge in both investigations and fines in the late 1990s. Most hospitals have figured that out. Most on-call physicians have figured that out too, and so that's why they're not taking ED call. All right? Why is that? Well, regulators increase EMTALA enforcement. The OIG does a thing, and they come in and look and says, well, these requirements are really difficult to meet and unevenly applied. And then guess what? Nobody wants to do that. You know what this is? This is the prescription of how to get your kids on the Dr. Phil show. All right? You give them an impossible task, they fail, and you punish them. All right? And then you're on the Dr. Phil show. All right? So you don't think it happens? Yeah, well, here's Dr. Chikuri, who was a general surgeon practicing in rural America, and 4 trauma patients come in all at once. He takes 2 of them to the OR, saves their lives. On the way to the OR, the other 2 have head injuries. He's not a neurosurgeon, he says transfer them to the other hospital. All right, and that's what happens. All right, the other 2 patients go, one of them dies, they get taken, the other one gets taken care of. And they come in and they say, oh, Dr. Chikuri, you forgot to do the paperwork, and therefore we are going to fine you $100,000, and oh, by the way, we're going to take away your ability to bill Medicare for 2 years. That was his experience. What was his crime? His crime was he didn't do the paperwork. All right? Everything else he did right. All right? And then there's the case of Dr. Shug in California, who was a pediatrician who was practicing at a rural hospital. Patient comes in the morning, vomiting diarrhea, looks like the flu, sends him home, comes back in the afternoon. Patient is more dehydrated, can't get an IV started as much as they try. And so what he does, it's going to take him a long time to get an ambulance. He says to the mother, take him to the children's hospital. It's about 45 minutes away, and they'll take care of him. So he puts the patient in a car and they go off. And of course, you know how this comes out. About 10 minutes prior to arrival to the other hospital, the patient codes and then dies. Okay, what's the answer? Anytime it's a pediatric patient, it's always a meningococcus, right? All right, so that's what happened. The patient had meningococcus and died. All right. Now the CMS comes in and investigates this. They thought it was such an egregious case, they actually reported to the state attorney general, who then brought murder charges against Dr. Shug. Okay. So they actually went to trial. They tried to, the prosecutors tried to present their case, and the judge threw it out saying you didn't prove anything. But he still had to defend himself. He had to go through all this aggravation. Okay, so who wants that business? That's the problem, all right? So it is the number 2, soon the number 1 issue with on-call issues with EMTALA, okay? So define how you fund and litigate healthcare, and eventually you will define healthcare itself. We've sort of already talked about this. Emergency medicine, 100% of what we do, $140,000 a year of lost income because of EMTALA. So, the next one is general surgery at $25,000, right? And then hand surgeons didn't even make the list, but they're the biggest whiners in the world, right? Again, it has more to do than just money. So CMS comes in and says, hey, well, let's relax the requirements, and maybe people will want to, I got 5 minutes? Or is that you?
No, you're good till 9.
Oh, okay, all right. I saw this note. So relax, maybe that'll make it better. So what they did is they came in and they increased the flexibility, of course, which just caused uncertainty. There was already an independent condition of participation for hospitals to staff the hospital appropriately. It said you have to have a prospective list, have to provide the coverage, and we talked about that already. Previously, it said if it's offered to the public, you must provide it to ED patients. That was the previous guidance. And then they came in and they said, well, what we are saying is whatever best meets the needs of the patient and the community served. How many people think that's better? Right, that's so ambiguous, nobody really knows what it means at this point, all right? They also came in and said you can do simultaneous coverage because there was an issue. The neurosurgeons brought this up, say, look, I'm on call at this hospital for neurosurgery, I can't be on call at the other 2 hospitals. All right, well, what happened was then, only one hospital had neurosurgery coverage. They said, no, you can do that. You can exempt senior medical staff from taking call. Hey, that sounds great, right? Once you're 50 or 55 or you've been on staff, you don't have to take call anymore. Except that it doesn't alleviate the hospital the requirement to provide the services. So you can exempt whoever you want to, as long as you provide the services. And you can do ad hoc as allowable if it's non-discriminatory. That's difficult. Remember, EMTALA, you are guilty until you prove yourself innocent. So it's very difficult to prove the negative. So that's not really that great either, all right? So there is no predetermined ratio. The rule of 3 doesn't exist. CMS just says, do it however you think is the best, and then when something goes wrong, we'll come in and tell you if you did it right. All right? Thank you very much. But they will not give guidance primarily because they do not have the authority to do that. All right? They said you have to have an advanced plan to deal with gaps in coverage. So if you do not have a neurosurgeon at all, or if you only have a neurosurgeon 1 week a month, you have to have a plan to deal with that gap in coverage. Right? So a lot of people sort of miss that. They thought, oh, well, we don't have a neurosurgeon, we'll just let the patient sit in the hallway and die. That doesn't really work. And again, nobody does that, but some people don't think about that, during daylight hours. A physician, not a group or a P, have to be listed, and you can use them for the initial evaluation, but ultimately, they want a doctor's name on that list. Why do you think they want a doctor's name? They want somebody to blame. They want somebody to hold accountable. So this, a couple hospitals gotten in trouble with this just recently, where they listed the physician group rather than a specific physician, all right? Even though they knew what physician was on call for that group. All right. So again, CMS will not really give you guidance about how to do it. So the problem is that you don't have the staff, so people are left. You don't have the cooperation. What are you going to do with outpatient follow-up and there's readmission procedures? All right. So how do you deal with that? Well, first of all, you should have some sort of EMTALA committee, or some group that understands EMTALA to deal with these issues. Okay, sometimes risk management, sometimes it's the medical executive committee, sometimes it's the ED committee, but you have to have somebody that understands it and to deal with on-call issues and everything else. You can deal with it through peer review, actually, interestingly enough, the state medical boards increasingly are getting involved. There's a case in Arizona where a on-call surgeon pediatric case was called. He initially said, well, I'm out to dinner with my family. I'll be there in a little while. They called somebody else who came in to take care of the patient. He then showed up about a half an hour later, saw that the child was being taken care of by another surgeon, so he left. All right? CMS got a complaint from somebody, came in, investigated, and wanted to cite the physician. CMS came in and investigated and said it's not an issue, but the state medical board got reported, and they actually sanctioned the physician for that behavior based upon EMTALA, even though CMS said it wasn't an issue. So again, another straw on the camel's back there, okay? So we talked about this. You do have these issues of generalists versus subspecialists. Anybody have this problem? It's what I call the right eye, left eye ophthalmologist. Yeah, it's Tuesdays. I don't take care of left eyes on Tuesday. That's on Wednesday. Call somebody else. Or we used to have this ENT guy, Dr. Daspit. I'll never forget this guy. This guy was like a world-renowned specialist in ears. He was an ENT surgeon, but he had to take call because he was on the medical staff. So, when he was on call, Dr. Daspit, ears only, right? And then somebody else was listed to take care of everything else. Well, a lot of times hospitals don't figure that out. The first, when our hospital mandated that the medical staff had to take on call, we went from about 5,000 physicians on staff to less than half that, because most of these people were just on staff or the big hospital. They don't really come there. So all those people were wiped out. All right? And then the first weekend of the mandatory call, the internal medicine on call was the director of quality for the hospital, who had not practiced medicine in 10 years. And he was at his cabin in Prescott somewhere, right? The hospital didn't understand what his privileges and what his role is within the hospital. Okay, it took us a while to work through that, but you get those issues. And you get the orthopedics guy. You have had this one, yeah? Right, so I practice general orthopedics, but I'm at this hospital. I don't do pediatrics. Really? Well, you do pediatrics at this hospital. Yeah, but I'm not really qualified. Really? I wonder what the medical board would say about that. So you get into these sort of issues as well, right? So these idea of core privileges, in other words, if you're an orthopedic surgeon, you should be able to do certain core things. We do that in emergency medicine, right? If you're a board-certified emergency physician, you should be able to do core things, otherwise you should practice. Same thing with the hospital. So you have to manage these privileges carefully, and most hospitals, not most, but some hospitals just really aren't very good at that. All right. So one of the things that we did was this is Congressman Shadig, Tom Scully, who was head of CMS, Leslie Norwalk, this is Senator Kyle, and the Arizona Medical Association brought them in. These are Arizona congressmen, and said, look, let's talk about the EMTALA thing. And for 45 minutes, I got to lead a discussion about this, all right? So Tom Scully, he's just started as the CMS director, and his first question was, what is EMTALA? All right. Now, this is the guy that's in charge of it. And so this gal, however, did understand it. She's a lawyer, and she actually was the interim director for a while. So what that resulted in was $1 billion of coverage for undocumented for EMTALA. It is the first time EMTALA has ever been funded. Interestingly enough, they didn't do it for Americans. They did it for foreign nationals. Right? But it was a recognition by the federal government for the very first time that they had an obligation to fund. Some of that money is actually still available. We got involved with them and told them the best way to do it, and they didn't listen to us, and so it was very difficult to actually get the money. But again, it was more of a ceremonial victory there. So we have this issue of the emergency department is at the center of the whole ecosystem here and on all the challenges. So I want to make one more point, and then I'm going to talk about more solutions. All right. So public policy does not supersede the laws of nature. Let me give you an example. So in the Exxon Valdez spill, they spent about an average of $80,000 per seal to recoup these seals, right? And then at a ceremony to release one of the more expensive ones, to celebrate this, a killer whale came and ate it, all right? So again, human behavior factors have to be accounted to in public policy. And I believe, personally, that's where the Obama plan is way off course. They have not considered the reaction that physicians will have to a decreased reimbursement of 20% plus all the taxes. All right? Anybody ever read the book Atlas Shrugged? Yeah, it's kind of like, give me enough, I'm going to say, I'm not going to do that anymore. All right. They have also not accounted for the behaviors that these will create with the American public. All right. And again, that's what we learned in Massachusetts. All right. So we have this on-call cycle where insurance companies say that it's a medical staff problem. The medical staff say it's a hospital problem. The hospitals say it's an insurance company problem. And then meanwhile, we're in the emergency department, twirling around trying to take care of patients. And then, where's the government in all this? All right, they haven't addressed this. And so the result of that is this. The hospitals with the specialist don't have the bed. Those with the bed don't have the specialist. All right, and those with the patient may not have either. All right, that's where we're at. Let me give you an example. Richard Nordmeyer was a patient at a local community hospital in Mesa. Had an intracranial bleed, and they called every hospital in the southwestern United States. Arizona, Southern California, Nevada, New Mexico. I'm not sure if they got to Colorado. Ultimately, he was transferred to San Francisco 8 hours later, where they decided not to do surgery because it was unnecessary, and he made a complete recovery. All right? Now, if that were you, your family member, what would you complain about? Right? Why wasn't there a neurosurgeon available in the whole southwestern United States? That's what I would complain about. What do you complain about? He complained about the $80,000 that his insurance company wouldn't pay for the transport. Right? This is how clueless the American, and that was, $45,000. So that's what the newspaper. So this is how clueless some of the people are. So what happened to this system? Well, it used to be voluntary. It's a sense of community. And in fact, that's the way I built my practice as I was a surgeon, general surgeon, or family practice. That's how I got my patients, right? That's long gone. So the margins were eliminated because you no longer needed that, and that's managed care. Managed care says, look, you don't have to go get your patients. We'll just assign you 10,000 lives, and we'll pay you so much per month to take care of these people. So I don't need that. So the marginal players drop off. And then we have this mandatory call because EMTALA enforcement starts in about 1994. Hospitals have the obligation, and so if you are privileged to be on the hospital, you're also privileged to take call because we have to provide this. And oh, by the way, we're not going to pay you. It's just one of the benefits you have of being on call. So then a few others were willing to take call, pour in reimbursement. The unassigned patients, which is all you get when you're on call because the assigned patients all go to the managed care people. All right, so that exacerbated it. And then this real, the enforcement with EMTALA really began in 1994. So this forces stage 4. Stage 4, where most of us are, is that we have serious shortages and specialists that just really found other places to practice. There is an orthopedic surgeon that does now minimally invasive spinal surgery. And he's using some endoscope to go in and take out, discs. So he's limited his practice to a point where he can practice Monday, Tuesday, Wednesday, and then he has the rest of the time off. He just follows up on these patients. So we're seeing that increasingly, and there's no one left to mandate. All right? So that really then leads to 5, which is the pay-based call. How many people pay your on-call specialists at your hospital? Some of them, right. So almost all hospitals are doing this now. And at least the hospitalists, surgicalists, specialists, orthopedicalists, you know, all the lists. And they actually start demanding payment. What's the highest amount of per diem that you ever heard of for an on-call physician? All right. Anybody have an idea? $2,000. How much? $2,000. Oh, not even close. Nope. Higher. $8,000 a night for a neurosurgeon, North Dakota. $8,000. Almost worth going to neurosurgery school for that. So then it becomes the no amount of money. How many believe that there is a no amount of money? How many people believe that? Yeah. So I tell you this story. So again, I'm practicing in Arizona, Phoenix, you know, a lot of foreign nationals. Patient is actually transferred from another hospital because he has appendicitis. I see the patient. Yeah, he does have appendicitis, pretty clear cut. The surgeons see the patient, says, yeah, he's got appendicitis, he needs to go to the OR, but we can't find an anesthesiologist. Really? There's a guy on call? Yeah, but you know, we called him, but he says he's really not on call. Really? I mean, you know, this is a big place. And so I call the guy up. He says, yeah, he says, I'm not really on call. Really? So some mix up in the call schedule. So I said, well, I don't know what to do. So I called the trauma anesthesia. Says, can you help me out here? He says, no, I'm covering trauma. If I go to OR, I got to close for trauma. So I call up Dale Schultz, who's the head of our, you know, system-wide 22 hospital malpractice thing. This guy has like $500 million of reserves, right? And I said, Dale, what should I do? This isn't going to be an Impala thing. I'm going to have to transfer this guy again because we don't have. He says, look, just call the guy back up and tell him I will pay him any amount of money. I believed him. The guy's got $500 million. All right, so I called the anesthesiologist up. I said, Dale Schultz says he'll pay you any amount of money. Nope, not going to do it. Really? I called 2 other anesthesiologists. Nope, no amount of money. And it wasn't like they didn't believe they weren't going to get paid. And ultimately, we closed to trauma, and trauma anesthesia took the patient to the OR. So we took that service out of there. So there are issues with no amount of money, okay? So we get to stage 7, where we see this acute care divergence. Small hospitals do routine care, specialty hospitals do, you know, these are physician-owned sort of profit. They do routine specialty care. And then we have what I call university model, which is the true specialty care. It may not be an academic medical center, but this is where most of that specialty care is being done because if they do the care that nobody else will do. It's typically a closed medical staff, so people are employed, and so they can mandate their behavior. All right, that's even becoming an issue too because they're having a difficult time hiring people to do that. Well, this is really where external public funding becomes vital. We do then move to stage 8, which is market-driven healthcare, where there's a physician glut that drives specialists back to the ED. We get this realignment of compensation, make ED lucrative. We have forced regulation, or the Israeli type system. Anybody ever been to Israel? So in Israel, everybody's, you know, is socialized medicine, national health care, and the orthopedic surgeons get paid a certain amount to do all the orthopedic surgery. But at nights, weekends, and holidays, they get paid on a per case basis. So it's the American system on nights, weekends, and holidays. So I talk to the ER guys, they can't get rid of them on the holidays, weekends, and nights because that's where they make their money. All right. So, or I like to call this the rapture. All right. And you can read about that in chapter 4. All right. So we haven't quite got there yet. So are we going to be this way where we have to like put a sign out that says these are the services we have available? And in fact, places are doing this. All right. What are the on-call lessons learned with, you know, the EMTALA Technical Advisory Group spent almost their first meeting talking about this. They came up with no solutions. It's not about money. It's really about principle. And we've done everything we want to do, and we have to start doing the things we never thought we would. Understanding why people don't want to take call is critical, as I said before. The American public have no idea how dangerous it's become to be ill or injured at the wrong time, right? When a surgeon is not available and you have a problem, all right? And you know how it always seems like the GI guy gets liver cancer, or the oncologist, you know, his mother gets ovarian cancer and all that. So you know, when I initially retired from clinical practice, I had a problem with a tree that fell on my roof. I thought, this can't be that difficult. I thought I could fix it. You know, I was standing on the roof. I stepped on a ladder. Piece of the roof broke away, fall down. 7 feet, break both legs. So I didn't go to the ER, of course. I just got in the house and my dad came over and put all the stuff away, and then, then I called a friend of mine and said, hey, I think I might have broke my leg. And the guy says, well, it's 4 o'clock in the afternoon. I can't see you today, but I can see you tomorrow at 9 o'clock. I say, yeah, good enough. So I get into the office, and the guy said, yeah, you broke your heel. You got a tibial plateau fracture. Why did you go to the ER? He says, hey, I work in the ER. I don't want to go there. And so then I said, well, the tibial plateau's got to be, surgerized. So I said, well, when can I do that? He says, well, everybody's gone. Waited a week to get my surgery. So the guy who's been talking about on-call issues for years, I suffer from the same problem, all right? So the chance of surviving a heart attack now depends more on the time of day of week, the type of insurance you have than any other factor. Who believes this? Really? Okay, well, it's been proven by multiple studies, all right? Fact is, if you don't have a cardiologist, an interventional cardiologist available within 90 minutes, your outcomes are going to be different. All right, so that's really where we're at. All right, sentinel events, 21% of the EDs were caused by an unavailable specialist. These are people who died because you didn't have a specialist available. These are serious problems. So as the on-call panels of hospitals erode, so goes the American safety net. All right, so I believe we're not there yet, and you can see this is from another country, but this is maybe where we're getting to. So, I don't know. Wanting just complaining for a very small hole. We can't solve problems with the same thinking that created them. I had the benefit of presenting at a conference where there was a bunch of healthcare economists, and I was later in the program, listened to them talk about, how we have too many doctors, too many hospitals, we're providing too much care, it's costing too much, and I got up there and basically said, hey, I'm not an economist, I'll prove that to you, because that's the kind of thinking that created the problem that we have today. We need more doctors, to solve this problem, all right? So they are non-solutions. You have to understand what those are. Mandating, by virtue of medical staff privileges oftentimes does not work. Malpractice liability is part of the issue, but it's not the entire solution. EMTALA certainly isn't. You can't legislate call, and requiring specialty hospitals to provide call at adjacent facilities, that doesn't work either. Those have all been tried, but certainly ignoring it doesn't solve the problem. All right, and I really like James Richardson. He's a lawyer in Tucson. And he said, hospitals physicians have to decide what they want to be to the community. That's the ultimate thing. If you're going to have your door open, you have to decide what you want to do. I believe about 80% of this is organization, only 20% is financial. Financial is important, but what I learned from talking to doctors is they want a sense of fairness because everybody else has left and they're the last one standing. And they just don't feel like that's fair, and it's not, all right? We can utilize and will have to utilize telemedicine more and more because the on-call specialty is just not going to be available where it's needed, all right? You can, as we did, we had this on-call specialty summit. We invited, a whole bunch of people, including governor's office or anything else. And what we learned, are these things, all right? So privilege coverage doesn't, is one way to do that. If you're privileged to be on staff, you're privileged to take call. You can contract for these services. You can employ the specialist. You can have an on-call IPA where everybody puts the money into a bucket and then it just gets doled out. So that, again, a sense of fairness. But really, I think it's a systems approach, which most hospitals really haven't gone to. They deal with it specialty by specialty, body part by body part, but it really needs to be a system, all right? We should start with what we have, not what we lack. So there's an example of that. This is actually a website where they can tell what specialists are on call where, so that you're at least not, dialing for doctors. How many people have done this? Like almost nobody, and we couldn't get it started in Arizona because the on-call specialists didn't want people to know where they were. All right, because now I'm on call for the whole state. You're on call for the whole United States, but that's another issue. All right. We did all these things, all right? Liability, we have all those things, but the problem keeps getting worse. You can contract with providers, okay? Just like you do for all the other services, for the lawn services and for the, cleaning and all that kind of stuff, all right? You can go to a university model and hire employees, okay? I think increasingly we're going to be doing that. You can use a physician management company. How many people, anybody in here do that? Where you have like a group that comes in and sort of manages the on-call? It's really popular in San Diego. Tried it in Phoenix, didn't really take hold. And we talked about that one already. So that's an example. That's just a company that does that. So the best ideas that I've heard are these. What we did for surgery is because we were a trauma center and the trauma doctor was in the trauma attending was in-house and we had a residency program, the residents took care of all on-call surgery cases. And the trauma attending was the attending for them. So this was like the best of all worlds. The residents loved it because previously they would get the patients, we know with the X right here that said cut here. They didn't get to do that evaluation in the emergency room. They didn't see patients fresh. So they loved it. The trauma attendants got paid a little bit more and really solved that on-call issue, which we had huge problems with that. Regional Hand Injury Rehabilitation Program, if you want to know more about that, email me. I have a write-up on it. That was the idea that, look, we're having hand surgery issues. So let's take all those patients and put them into sort of like a captive. And then we'll take the workman's comp and we'll put that money in there to pay everybody. And that helps us with the follow-up and everything else. So we actually proposed this. And when we did that, it scared the hand surgeons so much that they solved the problem for us. All right, they really didn't like that. All right, you can have acute care specialists. We've talked about all that as well. That's sort of like the emergency medicine model, taking the crumbs nobody wants and make them into lunch. We are going to have issues, however, going forward with a shortage of physicians. How long does it take to grow a neurosurgeon? Anybody know? About 18 years. And we have a huge shortage, so I'm not sure what we're going to do about that. We have to change the way we train and supply physicians. We need more physicians, not fewer. The theory that the more doctors you have, the more it costs, the more stuff that people will do is probably true, but the fact is that the opposite, by not having enough physicians, is not decreasing the cost. It's just killing people. All right? So we can fund the EMTALA mandate. That will help. We can have national standards for liability and Medicaid. Those are probably not going to happen anytime soon. And in fact, liability is not part of the healthcare reform. How many people believe that that's a good idea? That's a terrible idea. All right? So, we can do that a number of different ways, and it's not a lecture on liability, but you have to address liability. You can do that at a state level. You don't have to do it at the federal level. We recently, as I mentioned, Arizona have done that as well. Some other states have in addition to that. You can create these centers of excellence. They can't go on diversion. You have your neurosurgery center. You have your orthopedic center. You have your pediatric hospitals, all right? So sort of apply the EM principles to the on-call issues. Talked about a state department of medicine. So you have the state department of transportation that plans and builds roads. Why don't we have a state department of medicine that plans for the healthcare services for the whole state? All right, we need adequate physicians. We need adequate hospitals. We need adequate resources. Who plans all that? Currently, it's just on the free enterprise. That doesn't work all that well. All right, you can do special considerations, taxes, licensure. One of the greatest things that I heard was a hospital that if you take call, you get certain privileges, like you get to park certain places. You get your medical staff dues waived. You get to have first dibs. Like our hand surgeons said, look, I'll take hand surgery, but I want a block of 4 hours a day that I can have for hand surgery because I'm going to see all these people. I got to get it done the next day. Hospital said, great, you get 4 hours blocked every day. It was simple. Again, ask them what they want, what will make them happy, and that really works. Okay, so all these perks, right? It works. Change the culture. You got to stop stupid payment tricks with health plans, where, oh, you're not one of our providers. You saw the patient in the emergency department. We're going to administratively deny payment. We ended that in Arizona. You can end that administratively as well. And I have suggested to hospitals, because the hospitals will go out and they'll contract with XYZ plan, right? And then the patient shows up in the emergency department on XYZ plan. There's no medical staff in the whole hospital that accepts XYZ plan. That's crazy. I would tell the hospital, look, if you're going to contract with them, you have to get agreement from the plan to provide on-call and contracted physicians to provide for those patients. And the hospital says, well, if we do that, they won't contract with us. Okay, right, exactly. We don't want these contracts if we can't take care of the patients. All right? So again, I think that we have to stop managing by crisis. All right, I'm running a little out of time, but if this is something that I used for managed care. So what would happen if the patient would show up, managed care wouldn't pay. So I suggested, look, write them a letter and say, look, I'm not on a contract with you, but I will take care of your patients on call. Here's my price. You don't like it? Find your own guy. All right? Look, I've given you notice. It's going to be X, Y, Z. Here's my price list. This is what it's going to cost to take care of your patients. All right? And if you don't like it, find somebody else. And then I think that gives you a legal right to go sue them. So the hand surgeons did this. They basically canceled all of their plans. All right? And now they get full bill charges because nobody else will do it. So it worked for them. All right? So that thing will work. Okay? So again, I'm going to skip through some of this stuff. So bottom line is, in America, it's all about human behavior. And if you don't address that, the rats just keep jumping off the ship. You have to reduce the pain and understand what the issues are that cause them not to be there. At some point, you lose people permanently. And cooperation, cooperate, and cooperate. And I say that because oftentimes on-call physicians are denigrated by hospitals by not cooperating. But when you understand what the hospital does in playing hardball, they're not cooperating either. And you sometimes as the emergency physician understanding that, and again, having the patients in the middle of the night and having to deal with them can help with that. More resources, which is in your handout, and I'm just going to make one plug and then I'm done. So I have this compendium called the Point of Service Revenue Capture Program. It's how we took our uninsured rate from 34% to 15% and generated an additional $1 million of revenue to our hospital per year with zero cost. All right? You've heard about the triage out ideas that your hospital administrators go and they come back and say, this is a great idea, let's just stop them at the front door. All right, that's a bad idea. All right, this is the right idea. Get them in, take care of them, change your demographic. And you can do that by some simple things. And there's actually a business plan in this that you can follow as well. All right? So I call it the Turnstile ED and Charity Care Program. The Turnstile ED is just like when you go to Walgreens and you have to go through that little turnstile to get out. Right? What's been missing is the Charity Care Program. And again, that's all described in this. So you're going to capture a lot of people by sending them through the turnstile. People that aren't truly indigent, they're just truly uncooperative. They can pay, they just don't want to pay because they'd rather have an entertainment center. They don't want to do the paperwork for Medicaid, yet they could have services. There's a lot of those people. In fact, 40% of people in America who are uninsured could have insurance if they did the paperwork or they paid a small monthly premium for themselves or their family. All right, so we could almost cut it in half just by having people do a very small thing. The other half, you have to have a way to deal with them, and there are ways to do that. And again, that's talked about that. So I don't think we have so much a payment problem as we have a collecting problem. This is a lady that actually was in the hospital for a year, and they finally sued her to get her to leave the hospital. I don't understand that. I do understand this, is caution, vehicles do not stop for pedestrians. That's a way to generate business for your hospital. So I love Dr. Phil. The difference between winners and losers is winners just don't do the things, winners do the things that losers just don't want to do. All right. So if you thought your job sucked, I'm done. All right. Thank you very much.